It's really the expectation in the US that everybody jumps in. Yes. Nobody's too good to get that patient's mother a glass of water. Everybody has to be able to do that. That makes us a stronger team and a stronger healthcare system from that.
Absolutely.
So Jenny, today we are here to discuss some things that we kind of think are like myths about nursing in the US. So you've recently joined Shearwater.
Yes.
And you probably noticed the same thing that I did, that when we are talking to these nurses from other countries or our nurses who have recently arrived, that sometimes they had these expectations of what nursing is like in the US. And the reality can be very different. So we're always talking about how we want to set our nurses up for success and how can we frame expectations better. So today, there's an American show about myth busting. Let's myth bust nursing.
Bust some myths. So I think one of the things that I know we both hear a lot is they're just so excited to be here and they're so excited to start their career in the US and see what it's all about. And I think that there's a thought that nursing might be a little easier in the US. The truth of the matter is that nursing's hard wherever you are. Patients are sick, work is busy, there's a lot of patients to take care of. The ratios are still gonna be, 1 to 5, 1 to 6, even 1 to 8 in some areas when you're working in a med-surg environment, because we have a lot of sick people that need a lot of care. So there is still gonna be some challenges when it comes to your day-to-day work, but it is good to know that it's still going to be tough. Rewarding. Nursing is always rewarding, but it is tough.
We're able to bring nurses here to the US because there is a nursing shortage.
Right.
And a lot of our nurses come from countries that are experiencing that as well. And we all know the World Health Organization put out suggestions for the best nurse-to-patient ratios. And the US, I think a lot of our hospitals really strive for those great ratios, but you're right. In med-surg, we see, nurse to patient ratios of 1 nurse to 5 patients or 1 nurse to 8 patients and anywhere in between. In our ICUs, it's often 1 nurse to 2 patients. And I know a lot of our nurses come from countries where it's a 1-to-1. That sometimes creates some confusion. But I will say that we often have good supports even with those ratios. So we tend to have patient care assistants or nurse assistants. We have the great AccuDoses where the pharmacy brings the medications and they're stored on the unit. So our nurses are doing a lot less running around. So I think maybe there's less movement around the hospital for our nurses because they get to stay on their unit. But there's still a lot of work to be done. And our patients are so sick here.
Yes.
I talk to nurses who work on surgical floors in other countries, and they pre-admit their patients sometimes for days. And I like to think back to my husband who had his gallbladder removed, and we went in that morning, he had surgery, and 4 hours later we go home. And when I talk about that with our nurses, sometimes they're just shocked. We have such a network of clinics, doctors in the outpatient realm who are able to follow up and see our patients. We're able to push off some of that lower acuity care to be done at home or in that outpatient world, where in other countries that network doesn't really exist. So those patients are basically forced to be admitted because the doctors are so fearful they won't get the care they need or they won't be able to come back to surgery. And I think that is a big differentiator we have.
Oh, I agree. We've got a very robust home health here in the U.S. where we really strive for patients to be taken care of at home as much as possible. We want them to stay home. So those patients that come to the hospital are the sick of the sick. The really sick ones are going to take a lot more of your time. The acuity is going to be higher. They're going to need a lot more things. But like you said earlier, we have a great support system. Overall, everyone wants to help each other and be there for each other. So the patients are sick and the work is hard, but with all nursing, it's so rewarding to to care for your patients, and patients are so thankful and appreciative for the care that we give them.
I definitely think those are some of the best parts of every day, is just being able to see that impact and being able to see how the families are impacted by our ability to help these patients. So I think another one of the differences in the US is that we definitely have some technology advantages. And I think sometimes there's the expectation that technology makes everything easier. But I don't know if I would say that technology is making nursing easier. What do you think?
I agree. When I first started nursing, we did not have the computerized documentation. So I learned how to chart my assessments and all of my routine procedures on a flow sheet. And at the time, it was all I knew. But looking back on it now that I've been able to do all the computerized documentation, I realize how much longer it takes to document in the computer. There's just a lot more boxes to check. There's a lot more that we want to make sure we're documenting to make sure our patients are getting the best care, that we're not forgetting anything, that we're crossing all of our T's and dotting all of our I's when it comes to all of the preventative measures that we strive to keep our patients safe. So I think documenting in the computer is a lot more time consuming. And I think that that's something that a lot of people don't necessarily realize. You can kind of write out a note really quickly and you can check some boxes really quickly on paper. But when it comes to the computer, it's great when it comes to having all of that information on that patient all in one place. And that is a huge advantage. But the day-to-day shift work of documenting all of your assessments can definitely be more time consuming and just something to think about when you're transitioning to that.
Sure, it can feel tedious.
Yes.
I do think that one of the advantages it has given us, though, is, patient safety. So people might not realize that we have scanning systems for medication. So our medication orders are all entered into the computer, so our nurses can see those, and they have their workstation on wheels where they can roll their computer to the patient bedside, and they'll pull up the patient and see the med list, scan the med list, scan the patient, scan the medication. So in all of that scanning, if our nurses are following procedure, we're able to prevent so many errors. Because, sometimes the pharmacy tech, they stocked the AccuDose. They may have accidentally put 10 milligrams of lisinopril instead of 5 milligrams, and scanning that medication will typically catch it when you or I, sometimes I think when we're reading order after order, especially if we're tired, sometimes we'll miss that dosage difference, so because we're so used to looking at them. So I do appreciate those, and I do appreciate some of the indicators for patient safety it's been able to give us, reminding us to turn our patients every 2 hours.
Absolutely.
And reminding us, if we're in the ICU, when it's time to suction our patients, and all of those things to meet the Joint Commission best practices. So there's some things I love, but then the tedium of, the extensive feeling of documentation. So I would definitely say I feel like we kind of break even on, does technology make it easier? Easier, I don't know, but maybe better and more thorough. So for those people that you've worked with who are new to the technology, what's some advice you give them so that they can acclimate a little faster or get used to that technology a little bit more?
The biggest thing is don't be afraid to jump in and just do it. Let someone teach you, follow along with what they are doing. You've got to practice it. You've got to get in there. Don't be afraid to touch it and just start, actually letting someone watch you do it instead of standing back and observing and continuing to watch and wanting to make sure it's perfect in your head before you ever, touch a button. You don't have enough time to do that. It's really important that you actually get in there. They're watching you, they're checking behind you, they're making sure that you're safe. It's important that, we don't get too hands-offish because we're a little bit intimidated. Just continue to do it. You're gonna get it, with practice. Practice makes perfect. So that would be my biggest.
I think that is great and applies to all areas of nursing. Another thing I like to suggest to people is just get used to computers. Because I've just noticed, when we're teaching younger nurses who've grown up with the computers their entire life, they pick up on it a lot faster. And it's really just, there's general comfort with the computer. So for people who don't have computer comfort before coming in, learn to check your email and how to use all your email functions. Make sure you know how to write documents. Really do some research on what are normal communication patterns through the computer and through documentation in the US. And I think that's something that's really helpful.
That's great advice as well. You have a laptop at home, be on that laptop, be typing. We do a lot of clicking with the mouse, a lot of boxes. So just make sure that you're just as much as you can familiarizing yourself. I think that's great advice. One of the things that I think people think when they are coming over to the US is that the doctors have all the answers. It's been very apparent to me in interviewing that in a lot of areas of the world, doctors are a lot more hands-on with the day-to-day care of the patients. The nurses are there to assist them in any way that they can, but there's a lot of instances where the doctors are physically present on the ward to kind of do a lot of those things that they've been designated to do. Here in the US, our doctors are not present on our wards as much. They are in the clinic. They're seeing patients throughout the day. So they come in the morning to see the patients. They may come at lunch. Sometimes they come after their workday. But for the most part, they're relying on the nurses to assess those patients, keep them up to date on what's going on. If they have a change in condition, they want very specific, assessments and how their breathing is and what their labs are and what, you've been able to observe and assess through your own listening skills. So I think it's really important to understand that you are going to be very autonomous when you're here. You certainly have the support of your team and your charge nurse. Your nurse manager is very supportive, but the physician themselves, they're a little bit more removed. So you'll be speaking to them more via phone and doing more of the processes and the procedures and updating them that way than having them just directly at the bedside with you.
And this is one of my favorite parts about US nursing. You know me well enough by now that I really enjoy autonomy. And that's been one of my favorite areas of the nursing role in the US and how it contrasts to nursing in some other countries. And I think part of what created that autonomy is we have great relationships with our physicians, which is something we should be proud of as a country. Doctors really respect nurses, and I have worked with so many wonderful physicians who have really empowered me to make better decisions, be a better nurse, have better skills, and use a lot of opportunities for teaching. I think we have this great environment where nurses feel more empowered, and it's expected that we think and we're using critical thinking skills. So you're right, we work with our nurses to learn the SBAR form of communication, so when we're calling our doctors, we've done our homework before we've ever decided to pick up that phone. We've checked on that patient. We make sure we know who that patient is, why they're there, what has happened. And we've assessed the systems that are pertinent to the event. And we already have an idea in our mind of what is going on and what needs to be done. Because so many times in the US, when we call the doctor, they say, well, what do you want to do?
Right.
And it's so gratifying to hear that, they trust us and respect us so much. They're expecting us to have some of the answers too. So I love it when I'm able to give suggestions and the doctors are like, that sounds great. Call me if there's any other changes or if you need anything else. So I really do think it's one of the most gratifying things about our doctor-nurse relationship here, but it is something where, making sure that we're gaining the respect of the doctors and we're helping to develop that relationship. It definitely doesn't always happen right off the bat if they don't know you, but the more you work with them, the more that relationship develops. And then if you've worked in a teaching institution, every July 1st is a new batch of residents. So that is something you and I have both gotten to take part in. And working with learning doctors is awesome. And I also love how the senior doctors have now taught their younger doctors, like, hey, you might want to listen to the nurse. And the skill differences for doctors in the US and other countries, is that something you found interesting? In some countries, some of the doctors are doing the nursing skills as well, which we don't see as much here.
Yes. We don't see that as much here. And I don't know if that is because of the outpatient clinics and the things that we have that the doctors are also attending. But the nurses here are really more responsible for doing the skills, everything from inserting the Foley catheters, setting all the lines. Those are things that are very routine, common skills that we learn in nursing school and we start performing straight out of nursing school. So we don't have the physicians there. In fact, they would probably say, oh no, I would rather you do that. Trust me, you don't want me to do that, because they're not trained to do those things and they don't practice those things here. So they would much prefer that nursing do those, and that is a skill that we're expected to be able to do.
Especially those IVs.
Yes.
Our IV therapy teams are all nurses here, which I think would surprise people, which is a very fun team to be a part of. So
yeah. It was always my favorite. I loved starting IVs. So many of our nurses are wanting to come to the U.S. and get their graduate degrees, get their master's degrees, continue their education. We certainly find value in continuing to go on and get those graduate degrees. However, it is not a requirement here in the U.S. to have a graduate degree to be a fantastic, well-respected nurse at the bedside. Really, for a graduate degree nurse, you're really looking at doing something outside of bedside care. You're looking to maybe teach in university or do something more along the lines of administrative nursing. But to be a fantastic bedside nurse and to really care for your patients, you really don't have to pursue a graduate degree. And frankly, they're very expensive. I don't think people realize how much money it costs to go back to school. We all have to take out school loans and pay those back over time. So you really want to make sure and be very thoughtful about, if you're going to go for a graduate degree, how you're going to pay for that, and make sure you choose a direction that is really going to take your career where you want it to go.
We internally, within our hospital systems and within nursing culture in general, do so much extra education. We require a number of certifications that nurses have to keep up. Mm-hmm. We do skills competencies. We do so many educational in-services because medicine is so dynamic and nursing is so dynamic. There's always new standard operating procedures, a new medication protocol we're using for pneumonia. All of those things change. So we're constantly getting education through our hospitals. And I do think that's something that the US has done a very good job of, that we don't see in all of the countries from the nurses we talk to. And I also encourage people, sometimes when I'm talking to nurses, they don't necessarily know what they want to do with the graduate degree. So in the US, I would say that we have a lot more options for advanced education for nurses. So I always try to encourage nurses to get here first, get the lay of the land, and then really think about what you want to do with it. Here we have nurse practitioners. I'm a nurse practitioner, and it's something that I'm very proud of and love. But I was very thoughtful in why I wanted to do that. Even as nurse practitioners, I don't even know how many different types of nurse practitioners there are now. There's probably at least 15 different types of nurse practitioners, and we all have a different scope of practice. So I think it's really important for people to get here and to understand. And like you said, understand how to then pursue that degree, because there is financial cost to it. Yes. Now, typically you can make that up as you work after you get the degree, but that's something you have to be thoughtful in how you approach and be educated. Those are the biggest points that we should try to impress upon our nurses. We've talked a lot about different things. We've talked about, how nursing's not necessarily easier in the US. Technology doesn't necessarily make it easier. The doctor's expecting you to know what to do for everything. And I don't want to make it feel like you're not going to receive any support here, because I do feel like as a nurse, we have a great sense of teamwork.
Yes.
And I don't think we break up our teamwork necessarily in tasks. Like, when you're working, it's not like one nurse gives medications, one nurse does baths, one nurse does feedings. I really think of our support as more interdisciplinary, because there's so many different people responsible for getting patients to feel better, get healthier, get out of the hospital and go home and be successful at home, that I really think it creates a whole different dynamic of support and team.
I totally agree. And I had the privilege to speak with one of our nurses that arrived recently. And one of the things she told me was she was just really surprised at how much support she was getting, not only from her coworkers, coworkers on the floor, but from her educators and her nurse manager. And she just was so appreciative to realize that we are a team. And we recognize that this is very different. You're changing your whole culture, and you're learning to do nursing in a different kind of style, and the hospitals are different, and the technology is different. There's so many things to acclimate to. It was really neat to talk to her and just see her excitement and her joy and having so much support from everybody. And it's that way everywhere. It really is. We all want our nurses to be successful. It's our number one goal, is that they come over here and take great care of their patients and have a great time doing it, and really build a life and build community.
You and I are both the type of people who like to jump in, all hands on deck, and get involved and get our hands dirty. And that's one of the best parts about nursing leadership. There's so many times where I was working in an emergency room and we're just drowning because there's so many patients. They're not stopping. Nobody's eaten. You know, you don't have time to take your patient up to the ICU, and your nurse manager jumps in and is like, I got this. I'll take this patient up. One of our really good distinctions of nurse leaders in the US is it's not the idea that I'm going to look from above and, you know, just watch to make sure you're doing everything right. It's really the expectation in the US that everybody jumps in. Yes. Nobody's too good to get that patient's mother a glass of water. Everybody has to be able to do that. That makes us a stronger team and a stronger healthcare system from that.
Absolutely. So a lot of things that we see with some of our nurses is that they're really afraid to ask questions. I think they're afraid that if they ask too many questions, people are going to think they don't know what they're doing. And it really couldn't be further from the truth. We want you to ask questions. If you don't ask questions, then we start to get more concerned about you, because we know that nobody comes knowing everything. We all have a learning curve when we're doing something different and something new. If I went to another part of the world to practice nursing, I'd have a million questions, and I'd want to make sure that I knew what I was doing and that I was doing it all correctly. So asking questions is something that we welcome. We want you to do that because we want to make sure you have the tools you need to do your job and to effectively and safely take care of your patients.
I think when you said safely, you hit on such a key point. Yes. Patient safety is kind of like the end-all be-all principle of health in the US and many countries. But we really start to worry about, you know, if I'm training someone to do something and they don't ask me questions, I start to wonder if they're safe, because either they don't even know enough to start asking me questions, or they think they know everything and they're not insightful or introspective enough to realize that they're questions. So I really agree with you in that asking more questions is helpful. And always ask if you don't know, especially before you act. You know, if you're supposed to give a medication and you don't know why you're giving it, you should look it up or ask, always. And I think sometimes too, since we're dealing with people from different cultures and different communication styles, we also get a lot of people who it's just kind of inherent in them, if someone asks a question, to just give a single word answer, yes or no. Mm-hmm. It's maybe just nod ahead. And what you and I have really picked up on is sometimes that can send missed signals. So one of the things that we've really worked on, and you might have seen some success with this, is when we tell our nurses to paraphrase something. So if I say, hey, Jenny, can you go into room 6 and get that patient's blood pressure for me? Instead of just saying, sure, Melissa, or yes, you would say, great, Melissa, I'm going to go into room 6 and get that patient's blood pressure. And what that does is it gives me the opportunity to correct you if you got it wrong. And it also affirms, like, yes, I understand, I'm going to do this. Learning to ask questions and kind of learning the appropriate way to engage and respond are two really helpful things here.
Communication is a huge part of that teamwork and making sure that we're caring for our patients safely and that everything is getting done and we're not forgetting anything on our shift. And here in the US, you know, we are very open in our communication. We like to just tell you exactly what we need, and that is completely okay, and that's acceptable. And we want you to feel comfortable being able to do that too.
So we've talked about patient safety and how that's kind of paramount. But there's this other factor that is really a big discussion, and that's patient satisfaction. And I find that sometimes the fact that this is so important in the US can be surprising for our nurses. I'll tell them our hospitals are measured and graded on how patients and families perceive their care and how satisfied they are. That can be a little overwhelming, especially when you're new. So, when you're new, you're like, okay, I have all these tasks to do. I need to do these. And it's hard to remember that we also have to make people, the patients and their families, happy and satisfied and feel cared for. How do you find a way to balance those kind of two necessities, get all this care done, and then also make sure my patient and family are happy and satisfied?
I think it really boils down to that good communication, like we were kind of speaking of earlier. Providing excellent customer service, a big part of that is developing that relationship with that patient. So when you go in, instead of being just totally task focused and in the computer and trying to get all of your stuff done, take 5 minutes, sit with the patient, really look them in the eye and just have a conversation. How are you doing today? What are your goals for the day? What can I do today to make you more comfortable? And start to build a little bit of that trust so that they know that you hear them, you see them, they are a patient. And so then when they do have something that comes up that maybe they're a little bit intimidated to ask, if they've started to trust you a little bit, then they will be able to ask that question. So down the road, when they go home and they get that phone call that says, how was your stay in the hospital? What did you think of your nursing care? They're going to remember you and they're going to be like, oh, that nurse, she cared about me, or he cared about me. They took the time to sit with me and really listen to my concerns. So if you do nothing else, take those 5 minutes and connect with your patient. And it just goes so far in that impression on what they leave with and what they thought of the care. Even if down the road you're 10 minutes late getting them the medication they need or the juice that they've requested, what's going to stick with them is that you care, you took the time to really listen to them and hear them. And that goes a long way.
I really like two of the points you made. So one, sitting and talk to them. There's a study I read that says if you just sit when you talk to your patient, it gives the perception that you spent 10 to 15 minutes longer with them. And in the study, it said it didn't really matter how long you sat. It was the whole fact that you just sat down and looked at the patient eye to eye. So that's something I've personally incorporated into my practice and have noticed a big positive response in how people perceive me. Because sometimes when I sit and make that direct eye contact, my computer's to the side and I start with contact, they're like, oh, and they'll put down their phone or whatever they were doing. So I really appreciate that that's something that you have also emphasized. And I think the other thing I really liked is that you wanted to ask the patient about what's important to them. Sometimes as healthcare providers, we're assuming what's important to our patients, and we know what is on our task list of what we need to get done. But I think we sometimes forget that patient would like some more control. They would like to have some more choice and opinion of what's going on. And sometimes there's something that we haven't even thought about that is hindering their ability to rest or relax or focus. And sometimes it can be simple as like, it's really cold in here. Could I get another blanket? Or it could be, hey, could you help me call my daughter? She was in a car accident a couple of days ago and she can't come in and I'm worried about her. Can you help me? And those are things that we're not inherently going to think about. We wouldn't know unless we asked for them.
Well, and they know that we're busy. And so if we don't take that time to let them know that it's okay and figure those things out, then they more than likely won't ask at all. And then you've really missed being able to serve that patient and being able to really bring a little bit more comfort and customer service to their stay.
And I think one thing we haven't touched on yet is how to be approachable. So as nurses, I think one of the most important things we need to learn how to do is how to present ourselves as somebody that patients should trust, that we can talk to them. And one of the most simple ways to do that is the 3-5-10 rule. Like, how do you acknowledge your patients or people in general? So 10 feet away, we should be acknowledging that we see that person. About 5 feet away, we should smile. In some cultures, smiling isn't necessarily seen as the normal greeting. But in the US, when you smile at somebody, you are like opening a door or a window for conversation. You're coming approachable. And that at about 3 feet away, you should acknowledge somebody by name or greeting. So I think sometimes learning just simple things like that of how do you set yourself up for a successful interaction with a patient seems very basic, but eye contact, smiling, and greetings are really important in US culture. So that's something that if you can learn how to do that little piece, I think it sets the tone for the rest of your communications.
So when I have been speaking with nurses from around the world and doing their clinical interviews, one of the things that I have learned is that a big sticking point for a lot of them and a big frustration is when their colleagues or their coworkers do not come to work on time. And it seems to happen, just from my perception, it seems to happen fairly frequently in other parts of the world. So here in the US, it is the expectation that you arrive to work on time. And it is watched very closely. We have electronic time swipes. So you will be swiping your badge. It will, in the computer, mark the time that you arrive to work. And that is very closely monitored by your nursing managers on your unit. The beginning of the shift usually has a shift huddle where everyone comes together. And it's really important that you are there for that on time. There's a lot of important announcements that the charge nurse or the team leader usually makes at the beginning of that meeting. It's where you get your patient assignments on some units so that you know exactly where you're going to be going, who you're going to be giving report to or getting report from. So it's really important that you're here on time, that you're not missing the really important part of the beginning of the shift, and then that you're not delaying your coworkers from going home. We do work long 12-hour shifts here in the US, and everyone's tired at the end of their shift, and they're ready to go home. They're ready to give you that report so that they can go home and rest and come back to relieve you at the end of your shift. So it's just respectful to be on time, and you will also be held accountable. So if you're not, we have a little bit of grace usually. Things happen from time to time, but for the most part, you've got to be at work on time, or you will find yourself having an uncomfortable conversation with your nursing manager.
Around this timeliness, something that surprises our nurses when they come is that you can't clock in early either. Mm-hmm. Hospitals employ so many nurses or so many staff members. One of the ways they control cost is really creating that short window where you can clock in. So it's really important for our nurses to understand those time in, time out policies at their hospitals. So for example, one of them I worked in had a 7-minute window you could clock in. If you clocked in any time in the 7-minute window, you were on time. You could be penalized if it was too early or too late. So knowing when that time frame was really important. But if you were in that time frame, then you were there in plenty of time to get ready for your shift, to attend the huddle, to find out who you're going to give the bedside handover with. And then the other piece is lunches. Mm-hmm. So most of our nursing shifts here are 12 hours. Some people do work some 8-hour shifts, but for the most part, it's 12 hours. That's a really long time. Mm-hmm. And hospitals often automatically deduct 30 minutes from your pay or your time because they're assuming you're going to take a lunch. Please, nurses, take your lunch. I think you and I are always talking to nurses who are trying to work through their lunch break because they just feel like there's so much to do and they want to make sure they're doing it. But we really need to work on nurses taking better care of themselves. So I think you and I are forever having these conversations of it is really important you take that lunch, not so you're not paid for that 30 minutes, but so you give your mind a rest for a minute.
Absolutely. We all need to eat in that 12-hour period of time. And I think we ultimately take better care of our patients when we're taking a little bit better care of ourselves.
Yes.
It's important to decompress. And if you can get off of the unit altogether, go to the cafeteria. If they have a picnic area right outside the hospital, go sit at a picnic table outside if it's nice. Just completely decompress because it is stressful doing what we do. Patients are sick, they're demanding, we're tired, we're on our feet a lot. So let's take care of ourselves and have that 30-minute lunch. Hand your patients over. We are all working as a team, so you can give that little report, that kind of mini report, to a colleague. Let them watch your patients for you so that you can get off the floor and have a little bit of a rest.
Did you ever find a lunch buddy I used to like to go walk the stairs. Even though we walked a lot as nurses, but we're always all of us are trying to get healthier, always.
Especially on the night shift when you're trying to stay awake. Walk the stairs, go get some fresh air outside. I mean, it's amazing how rejuvenated you feel after all of that.
Agreed.